Okay, good morning. My name is dr.kang, and today I would like to talk about the comparison in clinical outcomes between the toric ArtiFlex, phakic IOL, and the spherical ArtiFlex with a limbal incision to correct myopia and moderate amounts of astigmatism. I have no financial interests, of course. The toric ArtiFlex is known to be effective, predictable, and stable in its astigmatic correction effects. It is also known to be safe. And as we are all aware that the correction of astigmatism has many facets. Limbal relaxing incisions, during cataract surgery, have been published are easy to follow and predictable, have predictable accuracy. And during toric IOL cataract surgery, though, high cylinder toric IOLs are known to achieve better clinical outcomes, and combined surgery for high amplitude cylinder toric IOLs with an LRI is known to be more effective. However, there have been no clinical studies to compare the outcomes between these two groups. So, our aim was to compare the clinical outcomes in these two groups, a toric ArtiFlex and an spherical ArtiFlex with a limbal incision, to see the amounts of astigmatism correction in eyes with corneal astigmatism between 2 to 3 diopters. It was retrospective in design. It included 540 eyes whose myopia ranged between 275 and -12, and whose cylinder ranged between 2 to 3. The usual exclusion criteria were, of course, enforced, and the usual preoperative measurements. At 4 months post-op, vision, refractive errors, and polar values of net astigmatism were found. Net astigmatism is a term that we define where M is the difference in the astigmatic power between two principal meridians, and where alpha is the direction of the steeper, the principal meridian. And to find a polar value for a given meridian, we have to enforce this complicated looking equation. And since most of these patients have with the rule astigmatism, and thus the incision is placed in the superior side, we calculated the KP90 and the 135 to calculate surgically induced astigmatism for the incision group. Preoperatively, the demographics show that there were no differences between these two groups regarding age, sex, laterality, and the amount of spherocylinder intended correction. However, the incision group did have a marginal and significant, slightly flatter corneas. Preoperatively also, the KP90 and 135 values did not differ significantly between these two groups, although the horizontal wide-to-wide and the chamber volume was slightly larger in the incision group. Post-operatively at 4 months, we can see that the incision group has a slightly more hyperopic shift in gold diopter. This is partially intentional because any incision would intentionally flatten the cornea, undercorrecting whatever spherocylinder correction that you had in mind initially. So we had to overcorrect it prior. The gold diopter was supposed to be in the hyperopic range. And for cylindrical correction, you can see here that the toric lens has marginally and significantly better cylindrical correction effects. However, this is just the net amount in diopters. If you look at the polar values after the postoperative correction, you can see that there are no statistically significant differences between these two groups. The toric ArtiFlex and the ArtiFlex with a limbal incision have the same astigmatic correction properties. And this is also regarding vision and endocounts. However, the first 30 days are the hardest for anyone with a limbal relaxing incision. Symptoms of dry eye, grittiness, the photophobia encountered with nocturnal glares seem to be very significantly more affected in the incision group. So this is a personal nomogram. This is not a scientific statement. I personally take the corneal thickness and the horizontal wide-to-wide to be the most important parameters to figure out the amount of correction in astigmatism that I intend. And the second most important thing is, I think, the size and location of the incision. The white to white, of course, is the size of the cornea, and we're trying to relax the corneal astigmatism, and that's the more flattening effect is achieved if the cornea is small. And so is the corneal thickness. It's more pliant if it's thinner, and it's much easier to manipulate. I always implant a parallel incision in the inferior part of the cornea if the corneal cylinder is more than 225 against the rule, with the rule, but always considering corneal thickness and the horizontal white to white. This is a surgical video of a toric. You see, I am marking very far behind clear cornea, almost into conjunctiva, because I don't want to affect the toricity or the corneal curvature in any way. This patient's corneal horizontal white to white was 11.2, so it was rather small, and any incision that would be in front of clear cornea would definitely interfere with cylinder. His corneal thickness was very thin. It was only 445, so I had to be very careful to make a small incision. And this is a 2.8 millimeter blade. I always put in a last-minute suture at the end of surgery. This is to solidify the incision, of course, but also to do minute adjustments to cylinder correction. I can always take it out early in the course of the post-op if the suture is putting on any tension. This is for a toric. Excuse me. Next slide. This is one with a spherical ArtiFlex with an incision. Notice that the incision is being placed very anteriorly into clear cornea. This eye has relatively large dimensions, 11.7 horizontal white to white, and relatively thick corneas compared to the previous video we just saw. He does have, with the rule, astigmatism of 275. So I'm enlarging the incision both ways. The incision has been placed, the lens has been placed, and I'm widening it out, measured about 5 millimeters. And of course, the inferior incision going right there, that is to be around 60 to 70% of corneal thickness in the periphery. The lens is placed very centrally. So, limbo relaxing incisions for the correction of corneal astigmatism in the moderate range between 2 to 3 diopters is safe, it's effective. However, there are more symptoms of dry eyes and night glares during the first month. It's safe, it's efficacious, it has comparable correction regarding cylinder, in visual, in endo counts, very stable spherical equivalence, stable astigmatism correction. However, more symptoms of dry eye and nocturnal glare, so we have to warn our patients of this. But when patients are getting the cost advantage of being implanted a spherical ArtiFlex instead of a toric, most patients are compliant with this. Of course, you have to warn them first. So when correcting astigmatism with our eyes, always pay close attention to white to white and corneal thickness. Thank you very much. Please contact me.